Have you ever seen a patient quietly struggling to hide embarrassment over urine leakage? Behind that moment lies a condition that is more than just a physical problem. It's a complex medical and emotional challenge. Today we'll break down the critical integrated map, CIM for urinary incontinence, a topic every nurse, doctor, medical student must master, because it combines anatomy, neurology, psychology, and compassionate care all in one condition. Let's begin with a clear definition. Urinary incontinence is the involuntary loss of urine due to impaired control of bladder storage or emptying mechanisms. In simple terms, the bladder and sphincters lose coordination, allowing urine to escape when it shouldn't. It's a symptom, not a disease itself. But it can have devastating impacts on a patient's quality of life, leading to shame, isolation, and even depression if not properly managed. Demographically, it's most common in women, especially after childbirth, menopause, and pelvic surgeries. In men, it often appears after prostate enlargement or prostate surgery. The risk increases with aging, obesity, neurological disorders like stroke or spinal cord injury, and chronic conditions such as diabetes. It's also more frequent in people with limited mobility or cognitive decline, making it a major issue in both community and hospital settings. When taking a patient's history, nurses should focus on the onset and pattern of leakage. Triggers such as coughing or sneezing, urgency, frequency, malturia, amount of leakage, and any use of pads or catheters. Always ask about obstetric and surgical history, medications, neurological symptoms, and the emotional impact, because understanding the pattern helps identify the type of incontinence: stress, urge, overflow, functional, or mixed. In stress incontinence, the sphincter or pelvic floor muscles weaken. When pressure in the abdomen increases from laughing, coughing, or lifting, the bladder leaks. A useful mnemonic to remember is STRESS. Sphincter weakness, trauma from childbirth, reduced estrogen, excess weight, surgery effect, sneezing or coughing trigger. In urge incontinence, the bladder contracts suddenly without permission. Lastly, mixed incontinence combines stress and urge types, often seen in older women, complicating both diagnosis and management. Let's move to medical management. The first step is always assessment and diagnosis: urinalysis, post-void residual measurement, bladder diary, urodynamic studies, and imaging when needed. Treatment depends on the cause. For mild stress incontinence, pelvic floor strengthening exercises, Kegels are the foundation. For urge incontinence, bladder training, timed voiding, and controlling fluid intake are essential. Pharmacologically, antimuscarinic drugs like oxybutynin or tolterodine reduce detrusor overactivity, while mirabegron, a beta-3 agonist, relaxes the bladder to increase capacity. Men with obstruction may benefit from tamsulosin or alfuzosin, which relax the bladder, neck, and prostate. In postmenopausal women, topical estrogen cream can strengthen urethral tissue. For severe or refractory cases, botulinum toxin injections into the bladder wall or surgical sling procedures can restore control. Surgical management is considered when conservative methods fail. The most common are midurethral sling procedures for stress incontinence, bladder neck suspensions, or artificial urinary sphincter implantation. For overflow due to prostate obstruction, transurethral resection of the prostate TURP is often performed. Neurogenic bladders may require intermittent catheterization or bladder augmentation. Now, let's talk about the nursing management, which is the heart of holistic care. Nurses are frontline educators and caregivers in urinary incontinence. Key actions include assessing patterns of leakage, maintaining a bladder diary, implementing scheduled toileting or prompted voiding, teaching pelvic floor muscle exercises, ensuring perineal care, preventing skin breakdown, and providing emotional support. Nurses should use the 3 Ps rule: protect skin, promote continence, and preserve dignity. At home, home care teaching includes maintaining adequate hydration, avoiding caffeine and alcohol, losing weight if overweight, performing daily Kegel exercises, wearing breathable pads, and seeking medical review if symptoms worsen or infection occurs. Patients should be encouraged to track fluid intake and urination times to identify patterns. For non-pharmacological management, lifestyle modifications are vital: bladder training, double voiding, weight reduction, avoiding constipation, and using bedside commodes for limited mobility patients. Education about managing triggers and maintaining skin hygiene cannot be overstated. Etiology varies widely, from pelvic floor trauma during childbirth, hormonal loss after menopause, neurological diseases like multiple sclerosis or stroke, structural problems like prolapse or enlarged prostate, and even chronic coughing or constipation that increases intra-abdominal pressure. Clinically, manifestations differ by type, but include leakage with exertion, urgency, dribbling, frequent urination, nocturia, and sometimes recurrent urinary tract infections or skin irritation. For labs and radiology, key investigations include urinalysis and culture, post-void residual volume measurement, bladder ultrasound, urodynamic testing, renal function tests, and cystoscopy for structural evaluation. In special situations like spinal cord injury or advanced dementia, a neurogenic bladder may develop where bladder control is completely lost. Nurses must then focus on scheduled catheterization, infection prevention, and skin care. To summarize, urinary incontinence is not merely a symptom. It's a window into how the nervous, muscular, and urinary systems interact. By integrating the critical integrated map-linking definition, etiology, pathophysiology, management, and nursing care, we can transform the way this condition is managed. The secret lies in early recognition, patient education, and empathetic care. Remember, as nurses and healthcare professionals, we don't just manage leakage, we restore dignity, confidence, and quality of life, one patient at a time.